Hello, and thank you for having me today. My name is Ann Lizardi, and today we're going to discuss prostate cancer evaluation and diagnosis. Disclosures here include I am a medical science liaison with Johnson & Johnson Innovative Medicine. My background includes my DNP, Doctor of Nursing Practice, at Thomas Jefferson University in Philadelphia, where I managed predominantly prostate and bladder cancer patients, but all GU oncology patients for nearly 17 years. I also was the director of the AUA, the American Urological Association APP National Program, and I was a board member with the Urology Care Foundation. So starting with clinical presentation for prostate cancer patients, most patients typically are actually asymptomatic, meaning they have no symptoms when they present. Most of the time, this is detected just via screening, which is why screening for prostate cancer is so important. Symptoms when patients have advanced disease include lower urinary tract symptoms like urgency, frequency, trouble emptying, or pain with urination, hematuria, meaning blood in their urine. In very advanced disease, patients will see bone pain, and that's because they have metastatic disease in their bones, and also then weight loss and/or fatigue. So screening consists of PSA, or prostate-specific antigen, which is a blood test. It is not specific for cancer, which is why it's not a perfect test, but it can be seen elevated in both BPH, or benign prostatic hypertrophy, or prostatitis, which is an infection of the prostate. Historically, we looked at ranges being in the normal range if they were below 4. However, we've realized in more recent times that PSA velocity is actually much more reliable. Also is age-adjusted PSA. The second component to screening is the digital rectal exam, or the DRE. What we're looking for here are palpable nodules or asymmetry of the gland itself. The DRE does have limited sensitivity and specificity, and it needs to be used in conjunction with the PSA. Here, this is a lengthy slide, but it's important to note that early detection of prostate cancer has to be a shared decision-making model. And these guidelines are set forth by the AUA, the American Urological Association, and the SUO, the Society for Urologic Oncology. So these guidelines say that, number one, clinicians should engage in that shared decision-making with patients for whom prostate cancer should be appropriate. When screening for prostate cancer, clinicians should use PSA as the first screening test. For patients with a newly elevated PSA, clinicians should repeat that PSA and make sure that it's a true value. Clinicians should begin prostate cancer screening and offer a baseline PSA to people between ages 45 to 50. But as noted here in number 5, to begin prostate screening earlier in patients who have an increased risk, so that includes patients of Black ancestry with a history of germline mutations and strong family history of prostate cancer. And that can be considered closer to age 40 or 45. Additionally, clinicians should offer regular prostate cancer screening every 2 to 4 years for people aged 50 to 69. And finally, clinicians may personalize the rescreening interval or decide to discontinue screening based upon patient preference, PSA, age, prostate cancer risk, and life expectancy. Here we're looking at, again, the joint AUA and SUO initial biopsy guidelines. Clinicians should inform patients undergoing a prostate biopsy that there is a risk of identifying a cancer with a sufficiently low risk of mortality. And some patients may not want to know that they have a really low-risk prostate cancer that will not be treated. Clinicians may use MRI, or magnetic resonance imaging, prior to initial biopsy to help increase the detection of a higher grade group prostate cancer. We'll discuss grade group later on. Radiologists should include PI-RADS in the reporting of multiparametric MRI imaging. For biopsy-naive patients, so patients who have never had a biopsy and who have a suspicious lesion on MRI, clinicians should perform targeted biopsies of the suspicious lesion and may also perform a systematic template biopsy. For patients with both an absence of suspicious findings on MRI and an elevated risk for a higher grade group prostate cancer, clinicians should proceed with a systematic biopsy. Clinicians may use adjunctive urine or serum markers when further risk stratification might help with decision-making. And finally, for patients with a PSA greater than 50 and no clinical concerns for infection or other cause for increased PSA, clinicians may omit the prostate biopsy in cases where treatment is needed immediately. These are the main biopsy methods that one might see. So on the left, you'll see the transrectal ultrasound-guided biopsy. So that picture there shows a probe in the rectum, and there's a channel within that ultrasound probe that the needle is placed. Next is a transperineal ultrasound guided biopsy. You can see there that the ultrasound probe is in the rectum. However, the biopsies are taken through that perineal region, which is the region between the scrotum and the rectum. And then finally, the MRI fusion biopsy, again, a transrectal ultrasound probe is used. However, the picture of the MRI that had been taken previously in days or weeks prior to the actual biopsy itself is fused over the picture of the live ultrasound view. This helps for targeting lesions. Imaging modalities include that MRI that we just noted, so multiparametric MRI for lesion detection and biopsy guidance, bone scan for metastatic evaluation, CAT scan or an MRI of the abdomen and pelvis for staging purposes, and then also a PSMA PET scan, which we've really seen used more so recently, and that's to help looking for advanced or metastatic disease. And it's, like I said, used earlier in disease states as well. Once we have tissue, we look at the histology and the Gleason grading. So the Gleason score, which has been used for many, many years, gives us actually two readings. They're the two most common patterns that are seen on the slide of the tissue under the microscope. And the cancer diagnosis is reported as a Gleason 6 through 10. What has become more recent use is grade grouping, and that corresponds with the Gleason score 1 through 5. And part of the reason that we've seen a change to grade grouping is that a Gleason score of 6 to 10 was concerning to a lot of, less educated patients because they hear 6 on a scale of 1 to 10, that's very concerning. So if we break it down, it's a little bit easier to understand when we're looking at grade grouping of 1 through 5. The higher the grade in either case indicates more aggressive cancer. Next, we have TNM staging. So T indicating tumor, that includes size and local extension, N, lymph node involvement, and then M, metastasis. This is used in conjunction with PSA and then that Gleason and grade grouping for risk stratification. So what our screening pathway includes, we start with screening with that PSA and DRE. If we see abnormal findings, we may consider that multiparametric MRI. Then we see either the MRI fusion or biopsy alone. That biopsy will give us tissue, which gives us the Gleason score, and then staging, followed by additional imaging as needed. In conclusion, we know that early detection can help improve outcomes because we're hopefully finding the cancer at earlier stages. Risk-adapted screening is key. The multiparametric MRI and targeted biopsy do improve diagnostic accuracy, and the Gleason score and staging help to guide management. These are my references, and I thank you for your time.